everyone, my name's Nivethitha Ram. I'm a fourth year from GKT. In this short video, I'll be going through some of the common side effects of psychoactive medication. First, we'll have a look at antipsychotics and neuroleptic malignant syndrome. Then we'll move on to looking at antidepressants, tricyclic overdoses, and serotonin syndrome.
There are two broad classes of antipsychotics, first generation or typical and second generation or atypical. While NICE does not recommend any one drug as the first line treatment, second generation antipsychotics are often preferred, and this is due to the lower risk of movement disorders. First generation antipsychotics include things like chlorpromazine, haloperidol, and flupentixol. Their key mechanism of action is their potent blockade of D2 dopamine receptors, and it's this dopaminergic blockade that also causes their adverse side effects, the main one being extrapyramidal symptoms. Second generation antipsychotics are things like quetiapine, olanzapine, risperidone, aripiprazole, and clozapine. They primarily affect other neurotransmitters, for example serotonin, and they have a lesser degree of dopamine antagonism, and this is why there's a lower risk of movement disorders. However, they can cause severe metabolic side effects, such as dyslipidemia and weight gain. Clozapine is particularly high in toxicity. It can cause serious, life-threatening side effects, for example, profound weight gain leading to obesity, agranulocytosis, which is the severe reduction in white cell count, myocarditis, and cardiomyopathy. Now let's have a look at the dopaminergic pathways. It's hypothesized that the overactivity of the mesolimbic pathway is what results in the positive symptoms of schizophrenia, such as hallucinations, delusions, and thought disorder. Therefore, blockade of this pathway is beneficial and improves these psychotic symptoms. However, the blockade of the mesocortical pathway that is already thought to be dysfunctional in psychosis results in the worsening of the negative symptoms of schizophrenia, such as the flattening of affect, reduced energy, anhedonia, and social disengagement. The blockade of the nigrostriatal pathway results in extrapyramidal symptoms, of which there are four main ones. Acute dystonia describes muscle spasm in any part of the body, for example, an oculogyric crisis in which a patient's eyes roll upwards, or torticollis in which the head and neck is twisted to the side. Parkinsonism describes signs and symptoms such as tremor, cogwheel rigidity, and bradykinesia, and these may be mistaken for depression or the negative symptoms of schizophrenia. Akathisia describes a state of inner restlessness where there is a strong desire or compulsion to move. For example, constantly pacing up and down, crossing and uncrossing of the leg, or tapping of the feet. This can be very distressing for patients. Tardive dyskinesia is a long-term side effect that may develop many years after the onset of treatment, and it can be irreversible and very debilitating. It is more common in older female patients. It describes abnormal involuntary movements such as lip smacking, tongue protrusion, or writhing upper limb movements known as chorioathetoid movements. Blockade of the tuberoinfundibular pathway, which mediates prolactin release, can result in hyperprolactinemia. This can cause gynecomastia, galactorrhea, menstrual disturbances in women, and sexual dysfunction. A long-term adverse consequence is also the reduction in bone mineral density. So we've discussed the extrapyramidal and hormonal adverse effects. Now let's look at the metabolic and cardiovascular ones. Morbidity and mortality from cardiovascular disease is higher in people with schizophrenia than in the general population, and this may be due to the severe metabolic adverse effects of atypical antipsychotics. Olanzapine and clozapine have the greatest effect on lipid profile, with mean triglyceride levels having been shown to double after 5 years of treatment with clozapine. This, when combined with the impaired glucose tolerance and profound weight gain, greatly increases the risk of diabetes and death from diabetic ketoacidosis, especially in younger adults. And as I say, clozapine is particularly implicated. ECG is always done as a baseline upon initiating an antipsychotic and upon inpatient admission. Cardiotoxicity is more commonly seen in atypical antipsychotics. Orthostatic hypotension is one of the most common adverse effects. Antipsychotics block cardiac potassium channels and are linked to the prolongation of the QT interval, which is a major risk factor for ventricular arrhythmia and sudden cardiac death. Olanzapine and risperidone are also associated with an increased risk of stroke in elderly patients when they're used to treat behavioural symptoms of dementia. Both classes of antipsychotics exert anticholinergic side effects. And it's also important to remember that another term for antipsychotics is major tranquilizers, and therefore they often cause profound sedation in patients. Neuroleptic malignant syndrome is a rare but life-threatening consequence of antipsychotic treatment. It's an acute disorder of thermoregulation and neuromotor control. It's most common after the initiation or increase in dosage of an antipsychotic medication. The onset is usually gradual over 1 to 3 days, and in 90% of cases, it occurs within the first 10 days after the onset of treatment. Presentation is often non-specific, so diagnosis can be challenging. It's characterized by muscular rigidity, hyperthermia, altered consciousness, and autonomic dysfunction. Autonomic instability can present as pallor, tachycardia, fluctuating blood pressure, excessive sweating, tremor, and incontinence. In terms of investigations, creatinine kinase is usually elevated, and the full blood count often shows leukocytosis. You can remember these with this mnemonic falter. Management involves withdrawing the antipsychotic medication for at least 5 days and rehydration. Agitated patients may require IV benzodiazepines. Bromocriptine is a dopaminergic drug, and dantrolene is a muscle relaxant, and these are often used, but this is only based on anecdotal evidence. So now moving on to antidepressants. There are 3 main classes: the newer selective serotonin reuptake inhibitors, SSRIs, and the older tricyclics and monoamine oxidase inhibitors. NICE guidelines recommend SSRIs as first-line pharmacological intervention since they are much better tolerated and have a much lower toxicity in overdose. Some SSRIs, such as fluoxetine, however, are potent inhibitors of hepatic cytochrome enzymes, and so they have a high propensity for drug interactions. This makes them less useful in patients with comorbidities. The most common side effects of SSRIs are gastrointestinal disturbance and headaches. There is also an increased risk of bleeds in the elderly. Therefore, SSRIs are avoided in conjunction with non-steroidal anti-inflammatories and warfarin. Tricyclics and MAO inhibitors are much less commonly prescribed for depression now, and this is due to their cardiotoxicity and their particularly high toxicity in overdose. Both are associated with postural hypotension and the development of cardiac arrhythmias. TCAs can also prolong the QT interval, affect cardiac contractility, and slow down cardiac conduction. Therefore, they are contraindicated after a myocardial infarction. In all antidepressants, there is a risk of increased suicidal ideation and self-harm, particularly in young people, during the early weeks of treatment. Therefore, it's really important that patients are warned about this and counselled on how to seek help. Tricyclic overdose is a common presentation since they have a narrow therapeutic index. Amitriptyline and dosulepin are particularly dangerous in overdose, especially when co-ingested with other substances. when suspected, it's important to establish what was taken, when it was taken, and how much was taken through history and by doing a serum paracetamol, a serum salicylate, and a urine drug screen. Typical ECG changes you might see are QT prolongation and sinus tachycardia that eventually progress to wide complex tachycardia and ventricular arrhythmias. The key signs and symptoms can be remembered with this useful mnemonic, HEARTS. You might also see neurological signs such as ataxia, increased muscular tone and hyperreflexia, and anticholinergic signs such as dilated pupils, warm dry skin and urinary retention. Management involves supportive care and monitoring. Intravenous fluids are given to correct hypotension, and a rapid sodium bicarbonate bolus followed by an infusion is given to improve acidosis and arrhythmia. Antiarrhythmic drugs are generally avoided as they may worsen QT prolongation. In particularly severe cases, gastrointestinal decontamination with a single dose of activated charcoal may be considered. Another rare but dangerous condition caused by serotonergic drugs is serotonin syndrome. The most commonly implicated are MAO inhibitors and SSRIs, especially when used together. It's difficult to diagnose and is often confused with neuroleptic malignant syndrome. It's characterized by the presence of this triad. Symptoms usually occur within the first 6 hours of taking the provoking drug, so a more acute onset than NMS. While mild cases may go unrecognized with non-specific symptoms, severe cases can cause severe hypothermia, acute delirium, and respiratory failure. The most important step of management is withdrawal of the offending medication. Benzodiazepines may be used to treat anxiety and provide sedation. Most deaths occur in the first 24 hours, so early management in critical care with sedation, intubation, and ventilation is key. And just as a final note, while these drugs act on one's neurochemistry, it is important to note that there still exists no conclusive evidence to demonstrate that mental illness is the result of a neurochemical disease process. In light of such severe and long-term adverse effects of these medications, at times prescribed and administered against a patient's will, it is important to interrogate the validity of the evidence base of their therapeutic efficacy. For more on this, I would recommend reading The Sedated Society by James Davies.
So thanks for listening, guys. I hope you found this video useful, and please see below for links to further resources.